I'd like to thank Dr. Teresa on behalf of KidsHeart for joining us today and giving us this really interesting talk on exploring the association and mechanisms between sleep and body weight. So we're all super excited to hear about this. Dr. Teresa is the chair of the psychology department from Zayed University, and she also has extensive research in sleep medicine. So I personally am very excited to hear a little bit more about this topic. And so whenever you're ready, Dr. Teresa, you can go ahead and get started.
That's great. Thank you so much for the introduction, and thank you for the invitation today. So I will go ahead and share my screen. And the purpose of today, I have pitched my talk and selected slides from different presentations that I've done over the years. I'm hoping that, because I don't know who my audience members are, so I'm pitching it so that it is understandable, I hope, to everybody. I will obviously have many minutes at the end, hopefully, to answer any of your questions. So I will work my way through the presentation, and then if you have any questions at the end, please feel free to just ask those questions, and we can discuss possible answers. So my talk and area of specialization is related to sleep and metabolic health. That's what I did my PhD in, and that will be the focus of, obviously, of today's talk. So we'll look at global and national prevalence of obesity. So what is it like in the world, and what is it like where we are in this region? And we'll talk about consequences and causes of obesity. And then I'll give you a very brief introduction to sleep and what it is and how we cycle through different stages of sleep. And then we'll kind of get into the nitty-gritty of this link between sleep and body weight. Then I will take you through the potential mechanisms that based on the scientific evidence that we have so far. And then we'll just briefly summarize. So I'm sure you kind of are all familiar with this kind of image, where we've got the body mass index calculated here. This is the equation for body mass index. And overweight, as many of us will know, is 25 to 29.9. And then obesity is classed as 30 and above. And so if we look at the rate of obesity here, the darker the blue, the more prevalent obesity is. So you can see that there's a particular problem in the US, and here we are in the UAE here. So we're kind of dark blue as well. But this is a global issue, and we're going to be looking at some of the reasons as to why this happens. So what about here in the UAE? Well, this was what I managed to find from Suleiman et al. In 2017. The statistics may well be different now, but I've highlighted the important bits here from this study. It's also important to note that this particular study is of expats, so we're not really capturing the national population here. But if we look here, overweight is about 43% in this population, this particular population, and 32.3% met the criteria for obesity. Okay, so we have a problem here with it, and it's also a global issue. So what are the causes, what are the consequences of obesity? Well, there are many, and I'm sure most of us are aware of most of these. So it not only affects the individual that's struggling with this issue, it also affects their family, and it's also a social problem. There's psychological aspects. So people with obesity tend to have more issues with anxiety and depression and other psychological illnesses. There's also physiological effects. So there's lots of other comorbidities, such as type 2 diabetes, which is also a big problem here in the UAE, but also at a global level. So the societal issues, there's issues for employers, and of course it places a huge burden on healthcare systems and the cost that obesity causes. So what is actually causing this issue? Well, this is easy. It's easy to answer this question, right? Because we have the energy balance equation. So we need to make sure, in order to not become overweight or obese, that this equation is balanced. So we need to make sure that energy expenditure is balanced with what we take in. When it becomes unbalanced, that's when it can create problems. So usually what we see is less energy expenditure and more energy intake, which kind of tips this equation, and then that obviously results in weight gain. So it's really easy. We know what causes obesity, but this is what modern day world living looks like nowadays. So we have McDonald's delivery here in the UAE. We have all these like Uber Eats, Talabat, Deliveroo. You know, basically you can get this type of food whatever time of day you want it, and it will be delivered to your door. So this is the energy intake side of the equation, and this is the expenditure. So this is what's happening. Who's taking the stairs? Well, one person in this image is taking the stairs, but they're coming down. Everyone that's going up are on the escalators. So, you know, increasingly we are seeing a problem with sedentariness and lack of exercise, despite all the guidelines that we have, and we know what we should be doing. But people want an easy way out. So is it really that easy? So it's really not that easy, because if we're thinking psychologically, I'm going to ask the question now, and if you can put in the chat box for me, which line would you be in here? Are you in this line where you actually want to make lifestyle changes and you're prepared to put in that effort and it's a long haul? Or are you in this line here where people are queuing up just to take a pill and that they want a quick fix? So where would you be at? Okay, excellent. So I've got someone saying that they would like to make lifestyle changes. But most people, because I'm assuming now from these responses that are coming in on the chat box, I'm assuming that we have lots of healthcare professionals on the call. So we know that lifestyle changes are really the best approach, but they take a lot of effort. And if we're asking people, patients, who are overweight or obese, who perhaps have a food or sugar addiction and don't like exercising, or it feels uncomfortable to exercise, they'll be in this line here, because people want a quick fix. They want this pill, they want it to work, they want surgery, because they feel that it can help them, and it's probably going to be quicker and easier for them to take this pill rather than adopt lifestyle changes. So this is what we're currently faced with. So is it really that easy? Is it easy to get this this energy balance? I suggest it is not. It's not easy for people to achieve this. Hence why people are gaining weight, and people are fitting more and more into this category of obesity. So the focus of this talk really is to look at sleep and how sleep has an influence on both sides of this energy balance equation. But I will be focusing more today, my talk, on this energy intake side of it. There are, at this point, I will say, there are evidence on this side as well about energy expenditure, but the majority of the evidence base is linking the energy intake with sleep. So I'm going to discuss like the early research that came about when we first discovered that sleep actually influences both sides of the energy balance equation. So is it really important? Is sleep really important? I think I've got some clinicians on the call in the audience. So I'm going to ask you the question. You're all going to answer yes, is sleep really important? But what I want to ask you is, do you ask your patients, if you're working in a clinical setting, do you ask them about their sleep? If I can just have a yes or a no in their chat box for those of you who are practicing. So Dr. Delalina, okay, all the people that are typing something in the chat box now, could you also tell me if you are working with children or if you are working with adults? Children, okay, adult, okay, so I've got a combination. Okay, so mostly children, some of you are working with adults, that helps. But I will talk to you about adult populations as well as how important sleep is in pediatrics. So of course, the answer is yes, sleep is really important. I'm just going to move that off my screen so I can see. Just 1 second, excuse me. Yeah, so you can see on the right side of the screen, the toddler that can just fall to sleep about in any place, wherever they are, they'll just crash, and they need sleep. So for children, we, even as children, spent about half of our childhood sleeping. It's super important for development. It's really important for brain development as well. And it's important for behavioral outcomes. So for children, absolutely it's important. Is it important for adults? Of course, it's important for us as well. So we actually spend 1/3 of our adulthood if we're basing that on 8 hours out of 24 in the day. So really, from an evolutionary perspective, it would have been a big mistake if we had evolved with sleep in you know the way that we have you know come about. And so we have to take note of this, because this behavior, sleep behavior, occurs across every species and all organisms studied to date. So I ask you to think about this. We can, as humans, we can resist the urge to eat. We can go on hunger strikes, and eventually you will die if you don't eat. You cannot do that with sleep. You can't, it's impossible. So you will eventually sleep. I think the world record of number of hours of complete wakefulness was 268 hours. And then eventually the person slept. They didn't die. They slept. And so it's really something that's really key and important at a biological level. And when we are sleeping, there's really complex stuff going on inside of us at a physiological level. So the answer is definitely yes, sleep is important. And I'm here today to really raise awareness of the importance and just talk to you about more about sleep and how we can educate our patients about sleep, how we can educate each other about sleep. So just some background, what happens when we sleep. We've got about a 90-minute sleep cycle. This is rule of thumb. It's not, you know, it's not set in stone. But this is roughly what happens. So from wakefulness, we start to enter so like a light sleep, which is called stage 1 sleep. That occurs for about 5 to 10 minutes. The eyes are rolling. We get alpha waves. The brain activity is starting to slow down a little bit from wakefulness. Then we enter into stage 2 sleep. That lasts, I don't know why that's happening, sorry. We enter stage 2 sleep. That lasts for about 15 minutes. That's still a light stage of sleep. So if I were to call your name during either stage 1 or 2, you would easily be woken, and you would maybe even think that you'd not been sleeping. Then if you progress on and you get into stage 3 sleep, that's more, we refer to this as slow wave sleep, that's deep sleep. So everything relaxes, the muscles relax, the breathing slows down. You're in a really deep stage of sleep, and this is characterized by something called delta waves. So they're like really large, sort of rolling waves that we would see on EEG activity. And your stage 3 sleep roughly in the first cycle is about 45 minutes. This is where all the restorative stuff happens. And then after stage 3, you go into REM sleep, which I'm sure many of you are familiar with, rapid eye movement sleep, that's what it stands for. That lasts in the first cycle about 20 to 25 minutes. It's characterized by quite a lot of brain activity. So if you're just looking at EEG activity, when someone's in REM, it might look like they're awake. The brain is highly active, it's doing stuff. There's a disconnect between the brain and the body, so the body becomes paralyzed. It's believed that it becomes paralyzed to prevent the individual from acting out dreams, because REM sleep, as many of you will know, is characterized by dreaming states as well. So everything kind of when we're in REM sleep looks a bit like wakefulness, but obviously we're not awake. And then we cycle back through these stages. We have about 4 or 5 of them each night if we are a sort of normal 7 to 8 hour sleeper. So how much do we actually need? So a group of sleep experts got together in the US, and they formed the National Sleep Foundation, and they came up with different categories for different age groups. And so I'm displaying those on the screen so you can look at, you know, maybe your patients. If you want to take a screenshot of that with your phone, that's good. You can do that and you can apply it in your clinical setting. Or if you're just curious to know about, you know, where your family member should be, or even yourself, this is quite useful. Of note here, this is a consensus of sleep experts. So they've all sat down and reached consensus about how much sleep individuals should be having based on their age range, okay? So it's important to note that there are individual differences, of course. We can't fit everybody into the same box. There are variations. So naturally, we have some adults who are short sleepers and have no obvious detrimental effects from 5 hours a night of sleep. This is what the reality is, though. So if we're saying an adult, the consensus of these experts say an adult should be sleeping 7 to 9 hours. What this data shows is the number or the percentage of adults in the US, this is US data, percentage of adults who are sleeping equal to or less than 6 hours a night. And what you can see, you've got men and women here, and you've got time comparison. So the data in light blue is from 1985. And then the data in dark blue is 20 years later. And what you can see is across every single age group, across men and women, this percentage is higher. So what does this mean? It means that across every single age group in terms of adult populations in the US, and compared to 1985 to 2004, the proportion of people has gone up who are sleeping 6 or less hours per night. So sleep deprivation is a real problem. And we're not just seeing that in the US. This data is from the US, just like this obesity data is from the US. So you can see over time, from 1990, 1995 to 2005, this is about the same sort of time as the previous slide. So you can see that sleep duration of 6 hours or less has increased substantially across men and women, across all age groups. But then this is happening at the same time. So this is really what led people, researchers in this sort of time frame, to connect the dots and ask this question: is this just coincidence that people are sleeping less than they were before, and obesity is becoming more of a problem than it ever has been before? It's not a coincidence, and we're going to talk about why it's not a coincidence, because I will share some data with you. But before I do that, I just want to share with you some some consequences of not getting good sleep. Now, at the minute, we're just focusing on sleep length. There are plenty of data out there that have focused on sleep quality, and the consequences of poor sleep quality are similar to what you're seeing on the screen here. So there are many consequences of poor sleep quality, or sleep deprivation. These can be psychological, they can be behavioral, or they can be physical. So what we're focusing on today is this one, the risk of obesity, because it is a very well-known consequence of sleep deprivation. So I'm going to share with you some of the data now. So where is all this evidence? In 1992, this was the very first ever published study that actually linked sleep with obesity. So we've known this for quite some time now. When I was doing my PhD, I started in 2008 and finished in 2011, graduated 2012. And when I was doing a literature review, like trawling through all this, there were around 500 published studies. Currently, there's a typo here. There's more than 1,000. There's way more than 1,000, and I'll share on the next slide just something that I found on PubMed, and the volume of these kind of studies coming through. So what kind of evidence do we have? So we maybe are familiar with this pyramid here, and right at the top we've got meta-analyses. So I'll talk to you about some of the meta-analyses that are out there, but we've got lots and lots of cross-sectional evidence. We've got longitudinal evidence where patients are followed over time, or healthy individuals are followed over time, and data points collected at various time points, and then looking for cause effect. We've got, let me go back. We've got experimental evidence where they've manipulated sleep, and I'll talk to you about some of those protocols and some of those findings as we progress through. Then we've got a whole host of systematic reviews and meta-analyses in this area. And it's important also to highlight that sleep can be measured objectively and subjectively. So for those of you that are not from a medical background or not from an academic background, when we're talking about objective measures, we're talking about the stuff that they put onto your head and look and determine the brain activity to assess whether you're awake or asleep. We call that EEG, or polysomnography. And then we've got subjective measures where the participants in research studies are actually subjectively reporting their sleep. I'm not going to go into the debate as to which is the best, but sleep researchers tend to like the objective measures of sleep, because they give us more detailed information. So just a quick search on this website, which many of you will be familiar with, pubmed.gov. This was a slide taken from a presentation that I did about 2 years ago. And just a quick search of sleep and obesity, those terms in PubMed, comes up with 13,500 results. I did the same thing today, and we now have more than 17,000. So this is really quite a popular field, one that's increasingly, attracting lots of scientists to explore in more detail. So they're still coming, and we're still learning more about this topic. So let me just take you through some of that evidence, some of the early evidence. So this was a birth cohort study called the ALSPAC study, so the Avon longitudinal study of parents and children. And what they did was they recruited about 14,000 pregnant women, and they followed them and their offspring. And I think they followed them into the teens. So this was a really large, very expensive study where they followed the kids. And this particular article that I'm sharing the data from, I think was when the children were toddlers. So they were 3 years old, and they what the authors were looking for is what were the determinants, what were the predictive factors of the 3-year-olds out of that cohort that met the criteria for obesity when they were just 3 years of age. And sleep duration was one of the strongest effect sizes that they found. So for kids this age, they recommend about 11 to 40, up to 14 hours of sleep. So they used more than 12 hours as the reference category, and they compared all these other categories. And what you can see is the lower the sleep duration, as in the less sleep the child is getting, the higher their risk, or the odds of them being obese at age 3 years of age. So this was really quite influential paper, and it gives us really good insight into how important sleep is at a very, very young age. This is some of my own research. So looked at young children. Now I was particularly interested in adolescents, and you can probably tell from my accent I'm from the UK. So when I was doing my PhD, this was really the focus of my PhD, whereby I did like an epidemiology study. There's like more than 600 teenagers, and I went into schools. We called this a Midlands Adolescent School Sleep Education Study. So the MASSES abbreviation. We have a couple of papers out based on the data that I collected there. So we went in and we collected data from these kids in schools in the Midlands region of the UK, and we found quite a strong negative association between body mass index, which was objectively measured. So we got the kids, we stood them on scales, we weighed, measured them, and we gave them a 7-day wrist actigraphy, which is like a watch, like your Fitbit or like your Apple Watch, to monitor sleep across the weekends and the weekdays. And we found that weekday sleep duration was a particular problem, because the less sleep they got, the more the higher their body mass index score was. And now we're moving on to adults, and this data is from Kripke, a very famous sleep researcher based in the US, and this was the American, I think it was the American Cancer Prevention Study, and it had something like 1.1 million people in the study. And this is just some data that were presented from this when they decided to look at, so we've got here at the bottom, hours of sleep. This is percentage of women, okay? And we have here at the top, body mass index. So what you can see here is that really the best thing, the best number of hours of sleep is 7 for this, because this is where you have the lowest BMI. So this BMI is healthy range. So is this one at 8 hours. This is healthy range. This one kind of okay, but here we're getting into the overweight category. So you see this U-shape association here. And this is the hazard ratio. So this is mortality data. So those sleeping 7 hours not only had the lowest body mass index score, but also had lower rates of mortality. So is this because of this or this? We don't really know yet. Probably a combination, but this is data from adults. If I may take your question at the end, if that's okay, we can always come back to the slides if that's okay. Is that good with you? Okay, I'm gonna assume that's okay. So now I want to just move on to the meta-analysis that was done by a group in Warwick in the UK and published in 2008. And what they did was they pulled all of the studies. You can see there's loads of them from the year 2000 right up to 2008. So 8 years worth of studies. and the pooled odds ratio is 1.55. So 55% increased risk if you're a short sleeper for obesity. That's what that means. If we look at the data from children, the same group, because they did it in adults and children. So if we look at the data for children, the risk is higher. So we've got an 89% increased risk. There's fewer studies, but it's a higher risk. So what does this tell us? It tells us that sleep's super important for pediatric populations in terms of risk of obesity. So we've looked at some of the evidence for the link between sleep and obesity. The prospective studies, you know, I talked to you about the one in children, but there are many, many more, which we don't have time to go through today, but I can guarantee you there are many, many more. We've also got experimental studies, and these consistently show that sleep impairment causes weight gain. So the question now that we should be asking as scientists is, how does this happen? Like, what are the actual mechanisms? And here they are. Maybe some of you are familiar with some of these terms. So we've got the hypothalamus here, and ghrelin is released from the stomach, and it sends a message up to the hypothalamus, signals to the brain that you're hungry. So higher levels of ghrelin. Ghrelin is known as the hunger hormone. So if your levels are high, that's usually like if you've been fasting for some time. So in the morning, after an overnight fast, your ghrelin levels will be high. When you eat, the ghrelin goes down. And then, I'm sorry, I keep touching the mouse and it keeps skipping the slides. Then on the other side, we've got something called ghrelin, which is released from the adipose tissues. It kind of signals satiety. So leptin is positively correlated with the adipose tissues. And it tells us that feeling of satisfaction, how full we are, tells us really when to stop. So what we know is that obese patients tend to be leptin resistant. So they have high levels, but it's not quite working properly for them. So to maintain energy balance, the leptin level should be high and the ghrelin level should be low. Okay, so just keep that in mind, because now I'm going to share with you some sleep studies that looked at these two appetite regulating hormones. So this guy here, Dr. Tahiri, he was my PhD supervisor, and when he was a postdoc, this is his work. So dates back, this was the first study that was published in this area that actually looked at leptin and ghrelin with in connection with sleep. And so what they did, this was conducted with the Wisconsin sleep cohort study. They mailed people, they recruited like 2,000, almost 3,000 individuals. These were all adults. They had half of them that came in for an overnight sleep study, full polysomnography, which you get things like the sleep duration, the sleep efficiency, how efficient are they at sleeping, how much wakefulness do they have during that sleep bout. And they also introduced a sleep diary later on. And after they'd done the night in the sleep lab, they took some morning blood samples. Obviously the patient, they were not patients, sorry, they were healthy volunteers. They took blood samples and they spun them down and took the plasma and looked at these appetite regulating hormones to see and make comparisons between the different sleep durations. And this is what they found. So if you're comparing the 8-hour sleep, so we're taking 8 as the reference, because this is really what we should all be aiming for as adults. And you compare them to the people that were naturally sleeping 5 hours. We don't know if they were sleep deprived or if this is just 5 hours is good enough for them. But when you look at body mass index, those who were shorter sleepers, 5-hour sleepers a night, 3.6% increase in body mass index, not a huge amount, but look at the leptin and the ghrelin. So the leptin was lower, which means they needed more of it to get that feeling of fullness, and the ghrelin was higher, which means that sleep deprived people or those who are sleeping 5 hours had higher levels of ghrelin, which means they were probably experiencing more signs of hunger, right? So that was an observational study. This data is data from an experimental sleep study about the same time. And this group is, I think they're based in Chicago, so this is still American data. But what they did was they had this sleep protocol where they brought people into the lab, they collected baseline data of what their sleep was like. Then they deprived them of sleep. They gave them a 4-hour sleep opportunity for 2 days and nights. And then after that, they gave them a 10-hour sleep opportunity. So they would be fully rested in that 10-hour opportunity. We've got leptin here, ghrelin here. And then they asked them subjectively on a 10-point Likert scale where they were in terms of their subjective hunger rating and where they were in terms of appetite here. So the darker line is the sleep deprivation, the 4-hour sleep opportunity for 2 nights. And what you can see is the leptin levels are lower compared to when they're well rested. The ghrelin levels are higher compared to when they're well rested. Their subjective hunger ratings are higher compared to when they are well rested. And their overall appetite when they are sleep deprived is higher. And we'll talk about what foods next, as compared to when they are well rested. So this really gave us some key insight, not only into the appetite regulating hormones and how they're affected by sleep manipulation or sleep deprivation, but also how the individual felt after the sleep deprivation and how it affected their appetite. So my question, what I wanted to know is, when I was doing my PhD, is how much sleep loss do you actually need for it to produce that effect? Because really, when you bring somebody into the lab and you wire them up with all this equipment and they're outside of their own environment, and you're really not going to sleep that well with all this stuff on you. You're also not in your own environment, your own bed. But 4 hours a night is really not representative of what most people actually achieve. And so I wanted to conduct a more realistic study to actually see how much sleep loss is actually needed to produce that type of effect. And also what types of food do people seek out more, or do they crave more? So I used this image on the right is an actigraph. This is similar to Fitbits and Apple Watches and stuff, but it's been validated against the polysomnography. So it's a much more accurate and better measure. So I did a very small pilot study just to look at this. So randomized, these were medical students that were recruited into the study, and I only recruited 5, and I randomized them either into 30 or 60-minute condition. So what do I mean by this? So we collected baseline data on them, on their sleep, using the wrist actigraphy. And let's say they were 8-hour sleeper. I would then ask them for 4 weeks to restrict by either 30 minutes or 60 minutes compared to what they were at baseline. And they would do that for 4 weeks. Then they would come back and we would take bloods and at each of these visits. Then they would do 4 weeks washout to kind of recuperate and get back to normal. And then they would do a 4 week of sleep extension. So this is visit number 6. And they would extend either by 30 or 60 minutes, depending on which condition they were randomized to. Now, at each of these visits, they would come in, they would have bloods taken across the day. And we would also, at the end of the day, give them a very large meal, and they did not know that we were measuring the food intake. So this was done in the hospital setting, and it was hospital food. We checked that they liked the food first. They had a menu, and we ordered 3 portions. And we gave them a starter, a main meal, and a dessert. And they were all 3 times. So there were 3 lots of these on one plate. So huge portions. And then we weighed and measured before and after. So we're looking at actual intake. And this is what we found. We didn't really find too much difference or any significant difference with the main meal, but we did in terms of sweets. So their cake consumption, if you look at the volunteers are down here, the 5 that we had, visit 3, this is their baseline. This is when they're sleep deprived, and this is when their sleep extended to their baseline. So you can see across all of them, except for this one, it's very close, but the cake consumption goes up when they're sleep deprived. So they're eating, they're more, they don't know that we're measuring this food and how much they're eating, but they all ate more cake. So maybe there's more craving towards sweet foods. That's what we found out. But bear in mind, this was a pilot study to see if it was doable. So it was only 5 individuals. More experimental evidence regarding sleep and feeding. Another randomized study. This one's a little bit later, 2013. Habitual sleep duration. They brought them into lab for 8 nights, allowed them to sleep as they normally would. And then they did 8 nights of 2/3 of their sleep duration. So let's say because I'm not good at math, but let's say if their habitual sleep duration was 9 hours, during this 2/3, they would be permitted 6 hours of sleep opportunity. And what you can see is that the SR stands for sleep restricted. So when they were sleep restricted compared to when they were well rested, they ate 566 more calories each day. So this is huge. This is really, really just an incredible finding. It's not compensated with energy expenditure. So they're not moving about more, but they're eating more. So if we think about this in the context of how much weight could be gained with this per day, just for sleeping less over a year, nothing else was changed. Let's look at it. So 100 calories is 1 chocolate biscuit, half a cup of milk, not much cheese for cheese lovers, or a scoop of ice cream. So that study was 566 calories per day. Just 100 calories excess is going to result in that much weight gain per year, okay, over 1 year, and then if you look over 5 years. So if people are in a more sleep-deprived state and the obesity levels have gone up, I propose to you that sleep is really, really important factor in this to consider, because it feeds into feeding behavior, what people are selecting. And this is the model, the mechanistic model. So you've got sleep loss here, which results in tiredness. So when we're not sleeping well, we have poor quality sleep, we don't have enough sleep, we experience tiredness, we feel tired, and that reduces our motivation to do what? To expend energy. So it reduces our physical activity. That's one cause of obesity. If we look this way, sleep loss means we have more time where we're awake. So we've got more opportunity to actually eat things. And what we want to eat, as we've just seen, is foods that are high in calories or high in fat. And that leads to obesity. Now, we've also got and learned, because I showed you some data, that when we are sleep deprived, we have lower levels of leptin. Therefore, it takes more and more to get that feeling of fullness. We have higher levels of ghrelin, which means we're more hungry. And there's other hormones, something called PYY, that's also implicated here. What does all this lead to? High levels of hunger, different types of food selection, not wanting to cook for yourself, just reaching for high energy type snacks. And this also leads into obesity. So that's the mechanistic approach to sleep and obesity. The next question maybe we want to be asking is, does it matter when you eat and when you sleep? And the answer to that is also yes, it does. So I just want to talk a little bit about something called chronotype. So that's like your natural preference of sleep and wake timing. It's to do with your circadian rhythm. And I've also done some with my adolescent data. I did some research on chronotype and what types of food the adolescents were reaching to, and they tended to be more evening types, so they function better later in the day. They struggle to get up in the morning, but they seek out different higher calorie dense foods. And similarly here, this is a similar finding here. So if you're a later type person, your odds of being overweight or obese are somewhat higher. So what actually does sleep look like in the UAE? Because the data that I've presented to you, much of it is from the US, and I showed you some of my data from the UK. This is what you're seeing on the screen now is data from the wrist actigraphy that we use and the software. And I'm just going to explain to you what this is. So these bits here in green and let's call it pink are sleep episodes. Okay, so you can see that this individual is fairly well aligned here across the weekday. They're kind of lined up, which means that they're going to bed similar time, getting up similar time. The blue is activity. So this is activity across the day. The yellow here is the lux of light, which is pretty pointless here because mostly it's on your wrist and it's covered and it's not really an accurate measure. So just ignore the yellow. This is what data looks like mostly in the adolescent data that I collected in the UK. This is not what it looks like here in the UAE. It looks more like this. It is very scattered. So I've collected data on my students at Zayed University, and it looks like a scatter plot. So we've got a lot of work to do here in this field about educating patients, about educating the public, and hopefully my message has sunk in that if nothing else, and you don't already do it, I want you to ask your patients about their sleep, because it feeds into so many other factors, not just diet, not just energy expenditure. It feeds into so many other illnesses. So I really hope that if you don't already do it, that you will start to ask your patients about sleep, or ask the parents about how the kids sleep. Don't ask parents about how adolescents sleep, because they typically don't know. So in summary, I hope I'm on time. Yep, that's good. We're doing good. Global obesity is becoming more prevalent. We already know that. The old views focus on this energy balance equation, and people think it's easy. They think they've solved it. It's easy. It's not easy because people don't want to put in the effort. And it's not just about energy intake and energy expenditure. Sleep is a big factor which influences both sides of that energy balance equation. So it's the third factor which we need to make sure we're assessing at the clinical level. I've given you lots and lots of data, not as much as there is. I don't have time to cover the 17,000, but I've given you some insight into how it's linked to sleep, and how sleep is linked to obesity, and how it impacts feeding behavior. This is mostly driven by excess energy intake, but doesn't necessarily impact the energy expenditure to compensate. Sleep is also related to those appetite regulating hormones. As we said, it kind of puts them out of balance, increases the levels of hunger, leaves people feeling less satisfied, therefore they eat more. So patients should definitely be asked about their sleep. Also bear this in mind if you're working in the weight management setting. Telling somebody to diet or go onto a diet or exercise, it's way easier to tell them to sleep more. If they're poor sleepers, it's way easier They want you to tell them that. Trust me. This is delightful for a patient to hear. Oh, sleep more. Okay, this is quite easy for them to do. So it's an easier approach. And even if it helps just helps them a little, maybe it makes them more cognitively aware, and maybe it helps them to implement more dieting strategies. So we should, as a minimum, be giving sleep hygiene education. And this is my take-home message to you. Sleep is a superpower. It's not a productivity killer. There are so many people that think sleep is a waste of time, and it's really not. It helps us in so many ways. So that's my summary. Those are my references. I'm sure the organizers will make my slides available. I give permission for that. I'd like to acknowledge and thank KidsHeart, and specifically Dr. Suleiman, for inviting me. Also to Zayed University for giving me a job and giving me a good standard of living here in the UAE. I love it here. And also for you, my audience members, for listening to me rattle on about sleep for the last 50 minutes. So now I am happy to take questions. If anyone wants to contact me, my email address is here, and my personal website you can visit to read any of my articles. Thank you very much for your attention.
Thank you, Dr. Teresa. That was great. Thank you so much. And thanks for emphasizing the importance of sleep. I think it's so important for us as physicians and pediatricians to always ask about sleep patterns. So I think that was really good to emphasize on. Thank you for that.
You're welcome. Anytime.
And I think we have a question. One of the questions was there any association between sleep deprivation and cognitive delay after a few years?
Absolutely. So there's so much literature out there now in terms of, I mean, the sleep and cognition field has been going for way longer than the sleep obesity field. And there's a cumulative effect. So the more you sleep deprive somebody, the worse they become cognitively. So it's like a dose dependent effect. And there's like so much literature coming out now about the effects of poor sleep patterns and Alzheimer's disease, and dementia, because what happens when we're not sleeping well, or should I say when we are sleeping well, what happens is there's like house cleaning going on in the brain, the lymphatic system, and so really the sleep helps to kind of flush away those plaques that's associated with things like Parkinson's disease, dementia, Alzheimer's. There's so much literature emerging in that field now. So yeah, definitely.
I think we have another question. In your research, did you find anything on sleep and eating disorders such as anorexia or bulimia?
No, I didn't, because that's not really my area of interest or expertise. So just to make it clear, I am not a practicing psychologist. I'm an academic. I've never practiced as a psychologist. I've never worked in the clinical setting except for within the research clinical setting. So I'm really sorry, I don't have the answer to that one.
And I think we have another interesting question. It says, is oversleeping counterproductive as well?
My personal belief, this is not based on evidence, is that you cannot oversleep. So some of you might say, well, no, sometimes I get 10 hours. Well, okay, you're probably getting 10 hours because you only had 3 the night before, or you've built up what we call sleep debt across the week. So when if you naturally need 8 hours sleep, and you're super busy on weekdays because you've got work commitments and you're only sleeping 6 hours or 5 hours, then you're 2 to 3 hours short each night. We call that sleep debt, and that accumulates across the week. And then weekend, we see what we call, sleep scientists call weekend catch-up sleep. So they try and catch up on all this lost sleep across the week. So my personal belief, not based on evidence, is that you cannot oversleep. You're just compensating for sleep loss that you've accumulated across the week.
And then an interesting question, something that I see a lot at my clinic. Do you have any tips to develop sleep with kids with autism? And of course, we see that a lot as developmental pediatricians.
Yeah, they're a very difficult population to work with in terms of sleep, just super difficult. And then also when you're working with children, you've got the added dimension of parents in there. So I think the first step is to educate the parents. That would be the approach that I would take. And I know I'm not a physician, but I know that there's certain medications, and maybe those medications are a bit counterintuitive to the sleep. So I think you need to be looking at what medications, maybe you can give them something different, try out different types of medications to see how that helps the child and sleep and behavioral issues that come with that. So definitely educating the parents is really key.
That's really interesting. It's a very complex kind of mechanism when it comes to kiddos that are on the spectrum. About 80% of them, 80% of children with autism spectrum disorder also have some sort of sleep difficulty, be it the onset latency or early morning waking. So I think it's just a very, very complex mechanism, but we appreciate your tips, obviously.
I mean, sorry, just to come back to that, I think educating the parents who are probably at the wit's end, and it's probably killing them, because it's just really, these kids are really difficult to manage, and the carers are not getting sufficient sleep. So it just exacerbates the problem, because when we're not well rested, we know it affects our mood as well. And, maybe we have a short temper. So I think, just education initially is really key, but then how you go about doing that, I think that is a real challenge. And I'm not an expert in that field. And actually, I don't really know who is an expert in that field. I don't know of anybody that's actually working with autistic children and their families in terms of, from a sleep perspective. There's data out there, but in terms of interventions, that's a really challenging one.
It is a very challenging one. And we have a lot of sleep medicine specialists that work hand in hand with us as developmental pediatricians. It's a very, very challenging a topic to tackle with families. And we know how much stress it puts on families, just like you mentioned. How can it be that vicious cycle where your sleep is off because the child's sleep is off, and then hence their behaviors are off, and it's just a vicious cycle. So I agree, it's very, very challenging. Someone had said Why We Sleep is a very good book to read. It's a very comprehensive one. That's interesting. I wonder if there's an audio book.
So that book was released a few years ago by Professor Matt Walker, who's at Berkeley in California. He's actually a friend of mine, and it's an excellent overview. It's good reading.
And then we have a couple more, Dr. Teresa, and I think we can wrap up. One of the slides showed increased BMI with sleep more than 10 hours.
So obviously this is the perception, isn't it? So if we take a step back from the information that I've just bombarded everybody with, and we think back to before all this evidence came out, one would think that obese patients might sleep more, because the perception is, well, they're lazy, they don't move about much, they're sleeping. And so the person, whoever asked that question, very observant, because you do see that, like I said, it's a U-shape association. So the key message here is 7 to 8 hours is good. It's good for, in terms of, extending mortality or longevity, and it's good in terms of body mass index. But being at this end of the spectrum or this end of the spectrum, it's like anything, you have to be in balance. So the balance here is 7 to 8 hours. If you're a long sleeper or a short sleeper, it's not good. But the short sleepers are at higher risk than the long sleepers. And there's not really that many long sleepers that we found in terms of epidemiology studies.
And then one last question before we wrap up. So for intermittent fast, does making most of the time and sleeping help for losing weight?
So when we are sleeping, I think we burn something like 80 calories an hour. Isn't that cool? I would say exercise is going to burn more, obviously, because you're moving about, therefore you're expending more energy. But it depends what type of fasting you're doing. If you're doing Ramadan fasting and your sleep is really out and you're super tired because you're having to work in the day, then I wouldn't be recommending too much exercise, because obviously you're not drinking either, right, during the Ramadan fast. So I would say, if it's not a Ramadan fast and you're intermittent fasting with water, then definitely exercise is going to promote weight loss better than sleep. It's got the edge for sure.
I was hoping the answer was the opposite, but
of course. But sleeping, achieving good sleep quality and achieving the right amount of sleep and being consistent with your sleep will help, right? Because it affects the way that we think about things. It affects what food we reach for. It affects our motivation level. It affects how tired we feel. It affects what food we want to eat. So yeah, pair it, a combination, I would say.
I will just say one thing before we conclude. I will thank Dr. Teresa very, very much for this beautiful, nice talk that enlightening a very important topic in our life. And thank you to Dr. Dalal, who's our expert in child development. And thank you for accepting our invitation. I will just say that we are very honored to be working side by side with Zayed University, where we are working currently to sign an official contract, I believe, from your side and from our side. And that student who's doing psychology will be coming to KidsHeart to get some form of internship during their growth. And that's an honor for us to be able to serve and help to promote a good psychology doctors in the future.
Thank you. Thank you so much for the invitation. And I really do hope it was useful for everybody. And thank you, Dr. Suleiman, for, I'm looking forward for that contract to be signed so that we can officially have that agreement.
Sure. All right. Thank you to everyone. Thank you, Dr. Dalal.
Thanks,
and
Dr.
have a great night.
Thank you so much.